welcome you all to the Gastric and Esophageal Cancer breakout session of this Living with Cancer Symposium. My name is Bossom Sonbol, and I'm one of the medical oncologists here that are focusing on gastric and esophageal cancers. And I'll be joined also with Dr. Almquist, who will be moderating this session in terms of taking your questions and trying to address most, if not all of them. I will also be joined later on with Dr. John Ashman. He's also one of our radiation oncologists who focuses on esophageal and gastric cancer. So this session, I mean, it's really meant to be kind of more of an interactive, informal type of session to kind of open up the discussion, open up questions that you as patients or caregivers have about esophageal and gastric cancer. So we always, I'm going to talk a little bit for about 10-15 minutes as a kind of overall landscape of diagnosis and treatment of these cancers, and then we can start taking questions. So overall, usually we kind of lump esophageal and gastric cancers together. However, we know that they are different. I mean, there are some things that are in common between esophageal and gastric cancer, but there are some differences, and we definitely treat them differently, and we do the diagnostic workup differently as well. First of all, as symptoms, we'll focus let's focus first on the gastric cancer, and then we can talk about the esophageal cancer. So gastric cancer is a cancer of the stomach, any part of the stomach. And although it's not as common as colon cancer, for example, it is one of the cancers that we see and we really take very seriously because it is one of the cancers that is considered aggressive. Now, there are some risk factors in gastric cancer. So, for example, smoking, alcohol are all risk factors. Obesity is another risk factor as well that we're aware of. And we know that gastric cancer is associated with the types of diet and also environmental exposures, because we know that it is more common in Asian countries than really here in the United States. And there are multiple theories and hypotheses why is that the case. Now, one of the symptoms that we see with gastric cancer is really depending on the location of the tumor itself. Sometimes patients present with anemia, so they feel fatigued and tired over a few months. And the reason for the fatigue is really because that tumor in the stomach might be oozing very slowly some blood in the stool without the patient noticing. So that represented by what we call anemia. So the hemoglobin drops, and that can cause fatigue. Sometimes also patients would have what we call early satiety, which means that they kind of come into us and say, hey, doc, I mean, I'm eating and I feel like I'm getting full very quickly. So that's also based on the location of the tumor. Also, in addition to that, if the tumor is, for example, located at the entry of the stomach or at the entry of the small bowels, where the stomach connects with the small bowels, that can cause what we call obstruction. So there will be a problem with the patients having symptoms of nausea, vomitings, and things like that. Now, one of the main questions that we ask when we have a patient with gastric cancer is has the cancer metastasized or not? Which means, has the cancer left the original place, which is the stomach, and gone somewhere else, what we call distant, for example, like to the lung, bone, liver, or things like that. And that distinction is very important because based on that, we kind of decide what the treatment landscape and treatment plan for such patients. For example, a patient who has gastric cancer or stomach cancer that's just localized and very small and very superficial, we usually ask our gastroenterology colleague to do a scope, and they can do kind of what we call resection of the tumor from with the endoscopy procedure. If the tumor, for example, is kind of it hasn't traveled anywhere else, which we call it non-metastatic, so it hasn't traveled anywhere else other than the stomach or maybe lymph nodes surrounding it, sometimes we incorporate a period of chemotherapy, and then we do surgery, and then we do additional chemotherapy later on as well. Of course, if the patient has a gastric cancer or stomach cancer that has traveled somewhere else, then at that time, the main treatment goal and the main treatment would be really to kind of relieve the symptoms and for the patient to live longer. And the treatment all depends on the patient, how the patient is doing, and also the tumor characteristics. So sometimes we do just chemotherapy, sometimes we combine it with chemotherapy and immunotherapy and other targeted therapies as well. And we of course have clinical trials to kind of help advancing the field and help patients with the treatments. Now, as you heard me saying, I mean, sometimes we do with the gastroenterology colleagues, sometimes with surgery, sometimes with just chemotherapy, and sometimes with radiation oncology. So that kind of tell you that gastric cancer, and also the same thing with esophageal cancer, as you will hear, it does need always multidisciplinary discussion, a multidisciplinary approach to come up with the plan. And for example, at Mayo Clinic, we meet every other week to discuss each case that comes in, each patient case with gastric cancer or esophageal cancer, and go into details with radiology, pathology, and others colleagues to kind of come up with the perfect plan for the patient based on the symptoms they're having. This is really in general how we approach the gastric cancer, and I can talk more later on and when we take questions about the kind of the recent advancements and other treatment approach. But for now, as I mentioned, I mean, I'll be joined when Dr. Ashman already joined us. He's one of the radiation oncology colleagues who focuses on treatment of esophageal and gastric cancer. And he will give us a little bit of talk on the landscape and the approach for esophageal cancer.
Great. I apologize for being late, and I'm going to get called away again just briefly to take care of a couple of patients. So I apologize for that bad timing today. But yeah, so esophageal cancer is different from gastric cancer in obviously its location. It's essentially located in the chest, so it's a different anatomic set of concerns, different set of surgical concerns. And we also think of esophageal cancer a little bit differently depending on its location in the esophagus. So we think of the esophagus a little bit divided into thirds. So the top part, or the cervical esophagus, is from the bottom of the throat to around the collarbone area. We call that the cervical esophagus. And then from about the collarbone area sort of to the mid chest, we term the mid esophagus. And then the lower third of the esophagus as you approach the stomach is called the distal esophagus. It's important for a couple of reasons. First of all, usually there are two major types of esophageal cancer that we're talking about. There is adenocarcinoma, which is the more stomach or gastric type of cancer, which is a glandular cancer. And we typically will find that in the lower part, or the lower third or distal part of the esophagus, or the junction of the esophagus and the stomach. Whereas in the upper parts of the esophagus, in the cervical or mid esophagus, we're typically dealing with what's called a squamous cell carcinoma, which is much more similar to a mouth or a throat type of cancer. The difference between an upper or a lower esophageal cancer is important for the different types of cancer because they respond differently to radiation and chemotherapy. And also from a surgical perspective, if the esophageal cancer is very high up in the neck, it would require removing the voice box or the larynx in order to do a complete resection. And so in those cases, we try to avoid surgery, whereas surgery in the middle of the esophagus is much more straightforward. Basically, you go above and below the tumor and can remove that part of the esophagus and then reconnect. And then surgery again lower down is possible, but also challenging for different reasons in terms of going above and below the tumor and then pulling up the esophagus into the chest or even all the way up into the neck sometimes. So, so anatomically, where the cancer is located is important. As I mentioned, the different squamous cell or adenocarcinomas are different sensitivities to radiation. So squamous cell carcinoma tends to be much more sensitive to chemotherapy and radiation, where we may be able to cure patients without surgery, whereas adenocarcinoma tends to be more resistant to radiation. We can cure a relatively small fraction with chemotherapy and radiation, but typically not enough to make chemotherapy and radiation be the mainstay of treatment. On the flip side, surgery alone is usually not enough to cure patients unless they have the very earliest of disease spread. If it's just a small tumor superficially into the wall of the esophagus, then surgery may be all that a patient needs. But once it goes deeper into the esophagus, through the wall of the esophagus, or involving lymph nodes, which are very common for esophageal cancer, then surgery alone, again, only cures about a quarter or a third of the patients, which is not enough. We need to do better than that. So that's what's evolved in the last few years, but especially in the last decade, the idea of what we call trimodality therapy, which is a combination of chemotherapy and radiation first as preoperative treatment, followed by surgery for essentially everybody with adenocarcinomas who's fit for surgery. And for most patients with squamous cell, unless we have a complete response with chemotherapy and radiation, and otherwise the patient may be at risk for surgery, we may not do surgery, may watch those patients after chemotherapy and radiation. There was a major trial from Europe a number of years ago now that looked at this paradigm of trimodality therapy, chemotherapy and radiation followed by surgery compared to surgery alone. And there was a clear benefit with more patients cured when all three treatments were combined compared to surgery alone. So that's where our current paradigm comes from. Now, the ways we're trying to do better is from a radiation perspective, using modern technology to try to reduce the short-term side effects, the side effects around surgery, because we know that giving radiation right before surgery can make the complications, increase the chance for complications, getting off the breathing machine, et cetera, heart rhythm problems when you're recovering from surgery. And then, of course, the potential long-term side effects of such heavy-duty treatment with radiation, chemotherapy, and surgery, especially with relation to long-term impact of radiation on the heart and lungs. So we're trying to use more sophisticated X-rays, which is what we think about when you're talking about radiation. We typically are thinking about X-rays, or a wholly different beam of radiation, which is proton beam, which is what we've been using since 2016, which is charged particle therapy. And we can get more into the details of protons and X-rays there. And then Dr. Sonbol can talk about some other ways we're trying to improve treatments with different chemotherapies or targeted therapies or immunotherapy, either in combination with chemotherapy and radiation or after treatment. There are different ways that we might be able to incorporate these new agents into the care of patients. We're especially interested in incorporating immunotherapy up front together with chemotherapy and radiation to hopefully continue to see improvements in the outcome for patients with esophageal cancer.
Perfect. Thank you, Dr. Ashman. It's a great introduction. I think, Dr. Almquist, I don't know if we have any questions or we can go into more details about some updates. If we have some questions, we can start taking them, I think.
So the first question, just are the life expectancies with gastric and esophageal cancer improving with time and with different modalities being addressed or implemented?
Yeah, that's a good question. Yeah, definitely. I mean, and if you look in the recent years, in the last 2 decades, there's definitely improvement in survival for gastric and esophageal cancer. And one of the main things that are driving this is, as Dr. Ashman mentioned, is really kind of the trimodality therapy that we know from that study that Dr. Ashman described. It showed improvement in survival overall for esophageal cancer. And we know now that we have more and more targeted therapies and immunotherapies that definitely led to improvement of survival, or what we refer to as overall survival, for patients with gastric and esophageal cancer. So we definitely are getting better in terms of the treatments we're given. And in addition to that, whether it's chemotherapy, immunotherapy, or even the radiation modalities, or even knowing more and more about how to treat this disease compared to before in the 20th century.
I see one question there from Susan. Dan, do you see that?
Yep. So there's a question of recurrent disease. If there's recurrent disease, someone who had esophagectomy with a gastric pull-up, if there's recurrent disease, would additional chemo and proton therapy help this patient?
Yeah, so the first part is what is the expectancy for squamous cell in the mid-discal tumor? I assume that might mean stage 3 before chemoradiation esophagectomy. Initially, we talked about improvements in outcome, but we still know that around 5 years, only about half the patients will be cured or will be alive at that point. So we still need to do better. Now, if you already had, we're talking about recurrent disease, and you had protons and chemotherapy, then we have to approach that in an individualized way, depending on exactly where the recurrence is, if there's evidence of spread outside of the local area. Are you a candidate for further surgery? The conventional wisdom is that we can only do radiation to one area once, but of course, there's no hard and fast rules, and so re-irradiation or a radiation or a second time is something that we do, that we consider, but it's something that has to be discussed in detail with the team and with patients, because obviously there's risks involved with that. I have to step away just a second. I will be back.
No worries. I think you're muted, Dr. Almquist.
Are there any new exciting therapies on the horizon, either for esophageal or gastric?
Yeah, no, definitely. So let me talk a little bit in more details about the treatment, or what we call systemic therapy for gastric and esophageal cancer. So as you heard, I mean, in general, whatever treatment that goes all over the body, this is what we call systemic therapy. By systemic therapy, under that umbrella, there is chemotherapy, immunotherapy, clinical trial, investigational medications, and things like that. So the medical oncologist role, which is me in this session, is really to kind of discuss always first the need of the systemic therapy, and also what systemic therapy to be given and for how long. Now, one of the things that we look at in any patient who come in with esophageal or gastric cancer is we do some testing on the tumor tissue. So especially for patients who have metastatic disease, we do testing specifically for a protein called HER2, HER2. That HER2 protein is found in it's variable, but about 1 out of 5, 1 out of 4 patients with esophageal or gastric cancer. The importance of that protein, if the patient has that protein in their cancer, again, this is testing on the cancer itself. This is like a target, or you can think of it of like an Achilles heel or weak point in that tumor, that we actually have targeted therapy with a drug called Herceptin or trastuzumab that can be given intravenously, goes all over the body to wherever the cancer cells are, hook up to these cancer cells and try killing them. So this is kind of more targeted therapy, and the testing for HER2 is very important. So that's one of the ones we test for. The second thing we test for, and it's also very important, something called MSI testing, or microsatellite instability, which is also testing on the tumor itself. We're basically testing in a simplified way, or testing if the tumor has a lot of mutations in them. Mutations are like errors in the computer cells, in the cells of these tumors in their computer. So if there is a lot of errors, or what we call MSI high status, the importance of that is that such patients, their cancer respond really, really well to immunotherapy. They can shrink with a really good shrinkage and really improvement in outcomes with immunotherapy. Now, the percentage of patients who have that status, the MSI high status, is about 5 to 6% of gastric or esophageal cancer patients. So again, those are the things we test for. And in addition to that, especially for metastatic cancer patients, we test for something also in the tumor tissue itself. We call it PD-L1 testing. That protein is also important because it can guide our treatment with immunotherapy or not. So I kind of mentioned immunotherapy multiple times. Immunotherapy is like chemotherapy. Chemotherapy is given intravenously, goes all over the body, and tries to attack the cancer. Now, immunotherapy is different. It's given intravenously, but it goes all over the body and activates the immune system to go and fight the cancer. So it's kind of killing the cancer in an indirect way. And we got excited about immunotherapy in the last 8 to 10 years with multiple cancers, because typically what we see with the difference with immunotherapy and chemotherapy, that patients who respond to immunotherapy, they usually tend to keep that response, which means if the cancer is shrinking, it shrinks for a really long time compared to chemotherapy. So that's why now you will see a lot of the immunotherapies are tried to be incorporated in the treatment. So just to give you an update, I mean, this symposium came in the right time, because just about 3-4 weeks ago, there was a big conference in Europe. Of course, it was virtual conference with COVID, but there were multiple important studies that really are changing or will change the standard of care. So to give you an example, you heard from Dr. Ashman that usually patients with esophageal cancer, that's kind of what we call locally advanced, so maybe it's in the esophagus and maybe involving some lymph nodes, they get treated with chemoradiation and then they go to surgery. In the past, we used to just do what we call observation after the surgery. We just follow patients very closely to monitor for any signs of the cancer coming back. Now, in the last few weeks, that study, what they did is they randomized patients. So a group of patients got the trimodality therapy, which is chemoradiation and then surgery. And another group of patients got chemoradiation and then surgery, and then got a treatment with immunotherapy for a period of time. And they found out in that study that patients who got the trimodality therapy and immunotherapy, actually adding immunotherapy improved significantly the cure rate in these patients at 3 years. So that's why this is something we got excited about, because always we want to try to increase the cure rate in such patients. Now, in addition to that as well, and in the same conference, there were a couple of studies looking at immunotherapy to be combined with chemotherapy, but mainly in patients who have metastatic esophageal or gastric cancer. So metastatic, as we mentioned, is kind of the cancer where it already traveled from the original place, which is the stomach or esophagus, and gone somewhere else. So in those studies, now we know there is, for a subset of patients, if they have, I mentioned that PD-L1 protein, if they have that protein over a specific percentage, they would benefit from adding immunotherapy to their chemotherapy combination, and they would live longer when we add immunotherapy. So all of these advancements, I mean, we got really excited about, and it's just things that happened in the last few weeks. So we know all of this, and we're trying to kind of add more to that with some of the clinical trials we have here, and I can discuss that later on as well. But I just want to take more questions if there is any questions.
Yeah, we have a question. I guess it'll be more of, what are risk factors for esophageal? What are risk factors for gastric? And how does Barrett's esophagitis play a role in this?
Dr. Ashman, you want to take that?
Sure. So risk factors for esophageal cancer, again, depend a little bit on the location. You know, we talked about the upper versus the lower. So for upper esophageal cancer, it's again similar to mouth and throat cancers. So classically, it's smoking, alcohol use that are the biggest contributors to upper esophageal cancer, the squamous cell. There are some less common things like achalasia, which is a motility problem. In some parts of the world, people have certain diets that are quite caustic to the esophagus and could cause upper esophageal cancer, but that's less common here in the United States. Certainly, if you've had a prior throat cancer, mouth or throat cancer, then you're at risk for esophageal cancer in the upper esophagus. Now, for the lower esophagus, we talked about the adenocarcinoma. It has more to do with a history of chronic reflux. Obesity can play a role in that, mostly because obesity probably leads to more reflux disease. So chronic heartburn. Smoking maybe less so. And then you get this entity called Barrett's esophagus or Barrett's esophagitis, which is related to chronic reflux. So you know that the stomach is very acidic, and the lining of the stomach is designed to tolerate that acidity. But if you have chronic reflux, then the acid in the stomach is washing up into the lower part of the esophagus, and the lining of the esophagus is not really prepared to deal with that acid. So over time, it changes the mucosal lining, and it impacts the health of the lining and creates what's called dysplasia. And that is a pre-malignant or pre-cancerous condition that can be a precursor to cancer. Now, in general, the risk of going from Barrett's esophagus to esophageal cancer is actually fairly low, but it's constant and it happens every year. About 1 in 200 patients will go from Barrett's esophagus to esophageal cancer. And so when we identify Barrett's esophagus, then we ask our gastroenterologist to follow those patients carefully to try to catch the progression early. In addition, we know that ablating or trying to get rid of the Barrett's esophagus, usually through an endoscopic procedure called radiofrequency ablation, can decrease the risk of progression to cancer. So we take Barrett's esophagus seriously if it's found, but it has to be thought of in a patient who fits those risk factors, has chronic heartburn, and say, oh, you should get an upper endoscopy to evaluate this. And then if you have it, to be followed.
Dr. Sonbol, what about gastric?
Yeah, so gastric cancer, the risk factors, we talked how alcohol is a risk factor, and smoking, of course. Obesity is one of the risk factors. And I kind of mentioned that there is a kind of environmental and diet component as well. One of the things that you might hear about is that there is a bacteria that's there. It's called H. pylori or Helicobacter pylori. That bacteria usually it's kind of environmentally spread. I mean, it's found, and there are a lot of people actually have it in the community without even knowing it and without causing problems to them. But in some patients, that bacteria can cause sometimes kind of changes in the stomach, and in the long run and long term, it is considered one of the risk factors for gastric cancer as well, in general. Now, of course, one of the things that always patients ask our family members is, is this cancer inherited or not? Now, gastric cancer or esophageal cancer, both of them, most of the times they're not inherited, but there are some what we call syndromes or things and that runs in the family. So gene mutations or changes in the computer of these cells that you inherit from your parents that put you at a higher risk for gastric or esophageal cancer. Like one of the things that you hear about is a syndrome called Lynch syndrome, and then there are other syndromes that are associated in there. So we always ask patients about, about their family history, any other cancers in the family, even different cancer. It doesn't have to be esophageal or gastric. So prostate cancer, colon cancer, or breast cancer, or cancers that can be associated together, to kind of assess based on that the need for referral for genetic counseling and getting the genetic testing done.
Thank you. So I just did a quick Twitter search, and there's a mention of a DKK1 protein in gastric cancer. Is there any clinical trials or anything upcoming for that protein as a potential targeted agent?
Yes. So it's a good question. The DKK protein is one of the proteins that found in gastric or gastroesophageal junction cancer, so the cancers that arise from the junction between stomach and esophagus. And it can be found in patients, and it has been seen to be associated with, kind of as a bad actor. So patients who have it have kind of worse prognosis. So right now, a lot of the things in the pipeline, and then a lot of, there are multiple drugs that are trying to target that protein to kind of improve the outcomes for such patients. We actually have a study in Mayo Clinic here. So for patients who have metastatic gastric or esophageal cancer, we start them on chemotherapy, which is the standard of care. And in addition to that, they get the immunotherapy. And in addition to that, target therapy directed to that DKK protein. It's a kind of a clinical trial, so it's all experimental. We're trying to kind of add on what we know already. I just mentioned that a few weeks ago, we learned that chemo plus immunotherapy works. So what we're trying with this trial is to know whether adding another drug to this combination might be helpful or not.
Thank you.
Yeah.
What do you recommend for families and patients going through this as like supportive resources? What does Mayo Clinic, or what do you guys offer? Because I know with radiation, sometimes you might have some difficulty swallowing. Even at baseline, when a patient presents with esophageal, they might have some difficulties with swallowing. What do you typically recommend, or who do you have them see to help with this?
Well, you bring up a good point, because one of the most important assessments that we make at the very beginning is what is the nutritional status of our patient. And it can vary widely from someone who just noticed a little bit of difficulty swallowing, or maybe just had heartburn and was scoped, but otherwise has had no real changes in their diet and has not lost any weight. And those patients are probably going to tolerate radiation and chemotherapy quite well, despite the side effects of treatment, as opposed to another patient who may not be able to swallow at all, maybe not even be able to swallow liquids, and may have lost a lot of weight and is quite weak. So we, first of all, will assess the patient as a team with our surgeons, together with myself, Dr. Sonbol, and our medical and radiation oncology team. And one of the first groups most patients will see our gastroenterology, typically at the beginning. And then we actually have at Mayo a separate gastroenterology subgroup that is dedicated to nutrition. And so some patients, all they need is counseling and nutrition and dietitians, nutritionists and dietitians, to help find a diet that maybe is softer or more liquid diet, but is nutritious enough to maintain their weight. And some patients need a feeding tube. And the feeding tube can be a really important part of the treatment in order to get your strength back, be able to start to gain weight, and to be able to tolerate the initial chemotherapy and radiation as you go towards surgery. A feeding tube is always scary to think about, but it's actually fairly straightforward. Our surgeons will put a small tube directly into the first part of the intestine just below the stomach so that you can get nutrition and hydration and medicine through that tube. No one really knows that you have it there. It's just underneath your clothes. And sometimes we do it if you can't swallow at all. Sometimes even if you can swallow, it's nice to have the feeding tube as an extra source of support, because as you go through radiation, one of the biggest side effects of radiation is burning with swallowing, what we call esophagitis, or inflammation of the esophagus, which is like having a sunburn on the inside of your throat. So as we go through the 5 weeks of radiation, it starts to really hurt when you swallow. And then people naturally don't want to eat or drink as much. And so getting dehydrated and losing weight can be a problem during chemotherapy and radiation. So for some patients, having a feeding tube is really a lifeline to help get through that. But that decision is really individualized. Now, every patient, no matter whether they need a feeding tube or not, can benefit from the nutrition and dietary resources that we have. Obviously, we check lab values regularly. We also have social work support, which is really important to help patients and their families with this kind of new world of dealing with cancer and dealing with a cancer that impacts your eating and nutrition.
Thank you. I know we don't have a surgeon present, but I was just curious, just to share some of this information. What's recovery like from surgery, from chemotherapy, from radiation? How long? And again, I know you just discussed supportive cares, but what's that process like for patients?
Well, the biggest thing from radiation is that it tends to make you tired. Part of that is the esophagitis. So then, you know, as you go through the radiation, it's burning with swallowing. You may eat a little bit less. You may get a little dehydrated. It just makes you tired. But in general, actually, the chemotherapy with the radiation is pretty well tolerated, and the radiation is pretty well tolerated. We follow patients very closely during radiation, seeing them at least once a week. And sometimes more to provide that support. Sometimes they need a little extra fluids to get through it. Typically, the worst side effects from radiation and chemotherapy is about the week after treatment is over. Patients think, I'm done, it's over, and then it kind of wave hits them. But that's sort of payback, because the first couple of weeks of treatment are nothing really happens. But everyone recovers by about 3 to 4 weeks after the radiation. We typically will see patients back about 4 weeks after chemoradiation, repeat imaging, see them back in the clinic, and almost uniformly patients will tell me, I really didn't feel so good for the first couple of weeks after chemoradiation, but now I'm doing pretty well. And I sort of turned the corner around 3 weeks after treatment and starting to feel pretty well. So we wait after chemotherapy and radiation, number one, to let the treatment continue to have a positive effect on the tumor, to see tumor die and shrink and make the job easier for the surgeons. And number two, we obviously want our patients to get their strength back prior to going into surgery. So surgery is typically around 6 weeks or so after chemotherapy and radiation. Now, the recovery from surgery, it's a difficult surgery. There's no question about it. It's a big surgery. It's made a lot easier these days with what we call minimally invasive techniques. So smaller incisions, fewer incisions, using cameras and robotic technology to do these surgeries through smaller incisions. And we know that that results in more rapid recovery, less trauma to the chest and the stomach, less blood loss, quicker recovery, less time in the hospital. And so I think, I don't know the exact numbers, but most patients are in and out of the hospital within probably 5 days, 7 days. A big part of this particular surgery is when they reconnect. So they cut the esophagus above and below, they pull up the stomach, and they reconnect somewhere in the chest. That's called the anastomosis. And a couple of days after surgery, they'll do a test to make sure that it's tight, that it's watertight, so to speak, that there's no leak in it. And because if there is a leak, then that can lead to infection and complications. Most of the time, everything looks good and patients are allowed to start swallowing again slowly, but patients will keep the feeding tube. Everyone gets a feeding tube after the surgery, and most of the time they'll keep that for several months after the surgery and slowly work their way back up to eating. I've heard from many patients that, you know, the pain in their chest can linger for a few months, but again, it's less nowadays than it was. Well, the old days are always the bad old days, but
right.
But things are better. But for most patients, it is a period of adapting to new life of swallowing. It's not going to, swallowing is not going to be exactly the same in terms of just going out and eating a steak right away. But usually by 6 to 12 months, patients have adapted quite well. And of course, the goal is that you're eating normally eventually. One of our colleagues in Rochester, Dr. Blackman is one of the senior surgeons there, has really been working on quality of life issues with patients, and actually has developed an app where patients can communicate with their surgeons, their nutritionists, their whole team about their recovery from surgery, what they're going through, and she can detect red flags based on that basically patient survey that, hey, this patient needs to come back in, or needs a phone call, needs some more intensive care, intensive TLC, so to speak, to help them swallowing. Whereas this patient over here, they're all in the green, things are going well on the right time frame. So that was a pilot trial in Rochester that we're hoping to soon expand to all 3 Mayo sites and beyond.
Well, we have another question that came in, and it's a question about endoscopy. So what are the chances of if someone who's elderly age could have complications from upper endoscopy, and what would those be?
So, of course, I mean, wish we had a gastroenterologist with us to kind of talk, because we have, as Dr. Ashman mentioned, also a team of kind of sub-GI doctors of our, what we call advanced endoscopists, so they can talk about that. But in general, yes, I mean, with, you know, the older the patient is, they are at high risk of any procedure that we do. But a lot of times, I mean, these procedures are done in patients who are elderly, and there are kind of the some of the complications of endoscopy. All depends on the procedure itself, of course, but sometimes, which is very rare, is what we call perforation. So that's when you know, the esophagus kind of rupture and some air can leak in. That's very rare, and it's a serious complication that's always have to be discussed. And a lot of times these procedures, I mean, they are tolerated, but they usually, you know, there is a kind of a careful discussion between the endoscopist and the patient about what the procedure is it indicated or not. And again, also depend whether the procedure is diagnostic or therapeutic. So diagnostic procedure means you're just going in with a camera and you're looking around, and you might do a biopsy or something. Now, of course, with biopsy, if you're on blood thinners, there is a risk for bleeding, or the bleeding can take more time to kind of recover. So they will advise you about kind of for how long do you have to hold the blood thinners before the procedure. So there's diagnostic, and then there's therapeutic. Therapeutic, which means they're going in with a scope, but they're doing something in. For example, in some patients with esophageal cancer, or selected patient with gastric cancer as well, they would go in and try to dilate if there is a stenosis or narrowing of the food pipe, the esophagus. They would go in and kind of do a dilation and put a stent in, so a kind of a metal stent that can be left in to kind of help with the swallowing, for example, or relieve any obstruction. So that by itself, it has its own risk, whether bleeding or the stent itself can migrate, so it can leave that place and go somewhere else. So those are things in general we kind of always think about with endoscopic procedure. It all depends on what you're doing down there when you're down there with the endoscopy.
In general, it's a pretty low risk procedure. It's minimal sedation, and just the act of the endoscopy is pretty non-invasive. So even elderly patients can tolerate it, unless, as you said, you're on blood thinners or you have heart rhythm abnormalities or some other reason if you're quite frail. But otherwise, it's a pretty safe procedure to do the diagnostic endoscopies.
Yep, I would say that. I mean, the complications are the exceptions, not the norm, really.
Yeah.
Right. The follow-up was, how do you if you start bleeding, what can they do? I'm assuming, they have sclerosis. They can inject chemical into these blood vessels and get hemostasis that way. But again, it's very rare that something like this would happen. Sometimes
Exactly.
they have to use that, to get hemostasis, or cautery, they call it, a little bit of electricity. But again, those are rare circumstances that they have to do that.
Well, in
Exactly.
fact, usually you use endoscopy to stop bleeding. For example, if you have an ulcer or some other reason to be bleeding, sometimes patients who have liver disease are more apt to bleed from their esophagus or stomach, and we actually use endoscopy to go in there and stop the bleeding.
I think that was the last of questions that we've received. Any final thoughts?
Well, I know I saw one comment from Susan that the feeding tube was more painful than the surgery sites, which I think is actually probably pretty common these days. Some patients can definitely have a pretty uncomfortable feeding tube, and the surgical incisions are getting less and less of a problem. So sometimes it is a feed. So we don't like to put feeding tubes in everybody unless we really feel that the patient needs the feeding tube up front. After surgery, everyone's going to have a feeding tube for a few months.
Yeah. And I'd like to add, in general, I think it's very, very important, not just for this cancer, but any cancer. Communication is the very most important thing. I mean, I always tell patients, you want to remember that, we as doctors, I mean, if we don't hear from the patient, we assume everything is going well with no problems and no issues. So if you're having problems, you're having symptom changes or things that need to be addressed, we want to hear about it. We want you to let us know about it so that we can address it and kind of make the appropriate recommendations or make the appropriate referral if needed. And that's especially important with the supportive care role of our teams. For example, we have the team of palliative care medicine or the supportive care doctors. They're a group of doctors and nurses. Even if you're getting treatment with radiation or chemotherapy or things like that, they're there to help to address some of the symptoms that you're having with kind of managing pain, constipation, and other things. So that's, I think, again, I mean, communication is a very important piece.
There was a follow-up question to the endoscopy complications. Can you fix a perforation or bleeding immediately, or can it be fatal? Well, now we're getting really down into worst case scenarios. That would be extremely unusual for there to be a fatal complication from endoscopy. Usually the bleeding can be controlled. I would say very rarely does a patient have to go straight from the endoscopy suite to surgery to have it fixed through an open surgery. But overall, endoscopies are extremely safe, very, very safe. But as you can see from esophageal cancer, there are many considerations for patients, many subtleties to taking care of patients with esophageal cancer, where we like to have a team that's really dedicated to patients taking care of esophageal cancer, from the endoscopists, as we talked about, with their skill with ultrasound to make the right diagnosis, to our pathologists who have to tell us what that tissue is telling us in terms of the diagnosis, our radiologists who are interpreting the CT scans and PET scans so that we can appropriately stage patients. And then here at Mayo, of course, we have medical oncologists, radiation oncologists, and surgeons who are really focused on this type of cancer and cancers of the GI tract or cancers in the chest, and everyone else on the team, because it's a challenging cancer for sure.
Definitely, I agree. Multidisciplinary team input and discussion is very important. That's why always recommended, even if not getting treatment at a tertiary center, is to get at least a second opinion for such cancer, where expertise and subspecialties are available. I think with that, Dr. Almquist, if you don't have any questions, I think we can conclude the session. Do you have any questions?
No more further questions on my end. Thank you guys for teaching all of us and sharing your wisdom with all of us. Appreciate it.
Thank you all. Appreciate it.
Thanks to everyone for joining, hopefully in person next year.